Good afternoon, everybody. As it is after 1 o'clock, we will make a start. I want to start by acknowledging the traditional owners of the land in which this event is taking place, the land of the Wurundjeri people of the Kulin Nation, and we pay respects to their elders and families past and present. My name is Michael Henderson. I'm the chairman of head of the Melanoma and Skin Service. I'm a surgeon here at Peter Mac. And you all know where you are. You're at Peter Mac, and this is Monday Live, sponsored by the Victorian Comprehensive Cancer Centre, which is much more than this building, although it's made at Peter Mac. There's an alliance of 10 major cancer organisations, hospitals, medical research institutions, and Australia's #1 university, the University of Melbourne. Individually, these organisations are leader in the sector. And together they represent a truly formidable force committed to working together. Now, today we're in for an absolute spectacular. We were all of us in the Melanoma and Skin Unit last week were very pleased and delighted to be able to attend the Society of Melanoma Research and the World Congress of Melanoma in Brisbane. And I might add that quite a number of the members of the service were involved in this meeting. But as a consequence, we have two very important international visitors who have taken time out of their busy schedule to come down to Melbourne to speak to us today. And it's not just speak to us today, they're going to spend time with colleagues that, who they work with and know, and it's a really exciting and important time. Our two colleagues that are visiting us today are Professor Dirk Schadendorf, who I'll introduce in a minute, and Professor Jurgen Becker, who Richard's going to introduce in a little while. Dirk Schadendorf is the Director of the Department of Dermatology and at the West German Cancer Centre at the University Hospital in Essen. He's involved in currently more than 30 clinical studies and is the current President of the German Dermatologic Cooperative Oncology Group, or DCOG, as it's known, and Chair-elect of the EIRTC Melanoma Group. He has a strong focus on translational research and has published more than 600 peer-reviewed papers. Dirk is a world expert and leader in his area, and it's a great pleasure to welcome him here to Peter Mac in the VCCC building. And I'm asking him to come forward and give his presentation.
Thank you, Richard, for this very kind introduction. It's a pleasure to be here in the new Peter Mac. I have been visiting Melbourne 4 years ago, so what a change. And that's actually very similar to the landscape of immuno-oncology in melanoma also. What a change. We're making really great progress. But we are also facing some challenges, and I have 30 minutes, and I'm going to tell you a little bit about the resistance to immunotherapies, and I'm trying to give that in a way that hopefully everybody is able to follow. So I think checkpoint blockade has become a new weapon against cancer. But what we also see, it's not a cure for everyone. There are patients who are responding, there are patients who are having a certain benefit, also a long-term benefit, but there is obviously also a subset, a larger subset of patients who has no response at all, or who is having benefit which is not long-lasting. So Christian Blank and Tom Schumacher and the group in Amsterdam, together with Tony Riebers, has brought forward this cancer immunogram, trying to put that into a concept which patient and which factors might influence responsiveness to checkpoint blockade. And you see here a list in black, which was actually originally described by Christian in Science last year, and already was adding some more factors during his last month's presentation of an update of this cancer immunogram at ESMO. So you see there are several factors, and the idea is if you have more factors involved, the likelihood that you're responding to this kind of treatment is higher. So response is usually mediated by T cells. And just to remind everyone, killing of tumor cells is mediated by cytotoxic T cells. And this is depending on interaction of T cell receptor and HLA class 1 molecule on the tumor cell. And this is leading, if this interaction takes place, then we have cytokine release, usually measured also as a gamma interferon release, leading to cytolytic destruction of the tumor cell. So that's the way how it usually is thought that tumor cells are being eliminated. So one of the parameters in the cancer immunogram, which I have shown you, is genetic instability, which is leading to a higher tumor mutational burden, which is shown here. One of the famous papers describing the mutational load of different tumors, and you see melanoma, but also lung cancers. The two cancers which are most responsive to checkpoint blockade have the highest mutational burden as part of this genetic instability, which could lead to good things like generation of neoantigens. So that's a concept behind this immunological phenomenon: higher tumor burden, better recognition, leading also to new neoantigens which are being recognized. And this has been shown over the last years in several publications, initially by the New York group. Alexander Snyder published that a certain number of mutations would lead also to an increased benefit of patients, and these were patients with melanoma treated with ipilimumab, CTLA-4 blockade, and also our group with a German network with a broad institute were able to demonstrate that mutational load is associated with benefit. And as you can see, do I have a pointer here somewhere, or do I do it with the mouse? All right. So you see here, patients which have a benefit and patients who didn't have a benefit in terms of long-term survival. You see it's a huge overlap. It's statistically significant difference if you analyze enough samples, but for personalized prediction, this is actually not going to work. And the same is true actually for neoantigen load. If you measure that, here are the means. They are clearly increased in the patient group who had a clinical benefit, but there's a large overlap. So that's tricky for personalized prediction which patient would respond to immunotherapy. And both examples here from Alexander Snyder and Eli van Allen are on melanoma samples treated with ipilimumab. And here we have another cohort from the Los Angeles group demonstrating the same phenomenon for PD-1 and lung cancer. So, not surprisingly, if you analyze now responses, and this is one example analyzing T cell receptor sequencing, T cell infiltration and T cell receptor clonal expansion is also associated with T cell response. And you see that here are two examples clearly demonstrating that receptor clonality of the T cell receptor at baseline, so before treatment, correlates nicely with response to PD-1 therapy, and that also this therapy, PD-1 blockade, is modulating the T cell receptor repertoire. What is also an interesting observation, which has not been explored in the clinical context, is that the clonality of neoantigens seems to be important for T cell reactivity and sensitivity to checkpoint blockade. This is taken from a publication of McGranahan and Charlie Swanton's group published last year in Science, demonstrating that the clonality is important and not the number of subclones which are present, which is shown here. That could have implications if you treat patients, for example, or pre-treat patients, for example, with chemotherapy. So just to come back to my initial slide, genetic instability as a good factor generating neoantigens, producing more T cells or T cell recognition. The other side of genetic instability and high mutational load is that sometimes genes are hit which are of critical importance for the immune response. And so I have highlighted here that this could also be a way of generating immune escape variants. And I will give you some examples of our work we have done over the last years. So this is an analysis of patient system where we have analyzed 4 different cell lines named here with these odd numbers. And you see these samples were derived from surgical resection samples, lymph nodes, taken over the period of 6 years in times where we have not used checkpoint blockade or any of these new methodologies, treatment modalities. And you see that, for example, this cell line had very nice class 1 expression, and also the third one had nice HLA class 1 expression on their cell surface, but 2 of these cell lines had lost HLA class 1 recognition on these FACS analysis, clearly making these cell lines non-susceptible to T cell recognition and destruction. So what has happened, just for educational purposes, that's a HLA class 1 complex, and this complex with a peptide, which is critical for T cell recognition, is stabilized by beta-2 microglobulin. And what you can see here is that those cell lines which have lost HLA class 1 expression, B and F, are not expressing this stabilizing beta-2 microglobulin chain. So therefore, this complex is not presented on the cell surface. So now have a closer look on the 2 cell lines which have class 1 expression, and this is shown here. You see that the peaks are different. And this is just a visual thing that the genetic basis somewhat is altered, just looking at this FACS scan. And genetic analysis clearly demonstrate that there's a HLA class 1 haplotype loss. So you see that the first cell line has all 6 haplotypes, which are demonstrated here. The third cell line here, which is still class 1 positive, has lost 1 HLA haplotype, 24, B15, and C03. Interestingly, when you look, what happens is that we are able to detect T cells against neoantigens, and these antigens, which were detected over the course of the disease, were presented by those haplotypes which got lost over time. You see A24, B15, these are those haplotypes which were lost, and therefore the recognition of T cells detecting these new antigen peptides were not effective anymore. So this is another way of escaping the T cell recognition in this patient system. So first take-home message, loss of T cell recognition and killing can be mediated by HLA haplotype loss, or also by beta-2 microglobulin loss. These are 2 ways how you can lose cytolytic activity. So now this was the interaction between T-cell receptor and the HLA class 1 complex with a peptide together. Now let's get a closer look on the cytokines which are released, so mainly interferon gamma. And this entire interferon gamma signaling business is a complicated procedure. You have heterodimers which are formed by the receptors. Then this interferon gamma heterodimer is signaling via JAK1 and JAK2 into the cell nucleus via the STAT molecules, and then subsequently there are interferon responsive elements which turn on the responsive genes. What happens in the tumor cells is there are different ways what is happening. There are anti-tumorigenic effects like enhanced antigen presentation, there is proliferation arrest, and the induction of apoptosis, but there are also other possibly more pro-tumorigenic effects like increased checkpoint ligand expression, like increase of PD-1 ligand expression on the cell surface. So genetic stability and hitting those components might generate tumor escape variants by inactivating some of these molecules, either the receptor molecules or the signal transduction molecules like JAK1, 2, and STAT molecules. This was the concept, and this has been demonstrated now over the last 18 months quite nicely. And actually, if you analyze, for example, the data of the TCGA which are available, then you see that on basis of the data which are there in the TCGA database, close to 500 melanoma samples without any treatment. These are melanoma tissue, usually metastasis without treatment. If you analyze, there are roughly 15% of samples which have interferon gamma pathway signaling genes affected by a mutation. And this is the red curve. If you look at the survival of these patients, they do not as good as those melanoma patients who are having no genetic alteration in their pathway molecules. And you can break that down. Whatever molecule you look at, these are here the gamma interferon molecules, STAT molecules, or interferon responsive molecules. That's always the same message. These are small numbers, but there is a clear difference which is statistically highly significant in favor of those patients who are having not the mutation or mutated have a loss of function and impaired tumor survival. There's another patient example which I would like to demonstrate. This is also a patient we have treated more than 15 years ago. You see, still with chemotherapy at that time and dendritic cell vaccine 17 years ago. And again, we took out a cutaneous metastasis to analyze and establish the cell line. And this cell line is shown here, shows some very interesting characteristics. You see, this is the bulk cell line, and we have analyzed again HLA class 2 expression, no expression. We had class 1 expression, nicely expressed, and PD-1 ligand expression. So that is the natural way this cell line was presenting. So if you add some interferon to the cell culture, you see induction of class 2, you see induction of class 1, and you see induction of PD-1 ligand expression. And you see always 2 peaks, clearly demonstrating and suggesting there are at least 2 populations in the cell cultures. And we have separated these by cell sorting and are able to identify a interferon resistant a subgroup of cells, and this is shown here. If you add gamma interferon, you don't see no induction anymore. And here is the sensitive cohort of melanoma cells, which clearly demonstrates interferon sensitivity by increase, for example, of class 2 expression. And this is paralleled by increase annexin, for example, also upon interferon stimulation. And if one analyzes now the molecules in the interferon gamma resistant pathway, you see that the clone or the subgroup of cells of this bulk culture, which is resistant, does not show any amplification of the JAK1, but the sensitive is still upregulating JAK1 expression, clearly associated with gamma interferon signaling. And if you go even down to the molecular analysis, you see that the sensitive cell lines has the wild type JAK1, and here is a point mutation, which is leading to this downregulation and knockout of the gene and functional loss of this gene in this particular cell clone. So how does JAK1 deficiency evolve? And actually you can do that also for other molecules. This is just one example as we have done it in our cell line. You have, for example, JAK1 is located on chromosome 1, usually 2 chromosomes. On both chromosomes the JAK1 is located. You can lose now a JAK1 either by a gene mutation on one chromosome, and the second one is still compensating for that. And only in a second step, when you have an allelic loss, genetic material which is lost, then you have lost both wild-type alleles. No JAK1 activity is able to be measured. Or the other way around, you have the intact chromosome present. You're losing some genetic material from the second chromosome, and in the second step, this active JAK1 is inactivated by a mutation. So these are the two variants which can happen. And if we look in our cell line, I don't know whether you can see it on the screen here, much better than on my screen here. You see here the B cells as a control. You have the sensitive and the resistant subclones, indicating already a loss of the allelic distribution. And then as a second step in the resistant cell clone, you find the mutation. So this is actually the mechanism how in this particular cell line JAK1 was lost. And this is the evolution in our patient as we have analyzed it. Initially, the interferon signaling was present in the sensitive part of the cell line. There was still one chromosome present, and interferon signaling was detectable, and subsequently the JAK1 was mutated and the signaling was lost. So if one now not only looks into one cell system and one patient system, we have analyzed 46 human melanoma cell lines, and you see roughly 15%, very similar to the 15% we have seen in the TCGA database. You find mutations in the interferon gamma signaling pathway, and we have also verified that by staining in the tissue. So that's a common thing in patients not having seen any kind of treatment. The interesting twist of this observation comes with this publication by Tony Rieber's group last year in the New England Journal, describing a patient, or actually two patients, who had this JAK1/2 mutation present in a patient who initially responded to checkpoint blockade with a PD-1 antibody. So initially, this was a baseline tumor, then there was a regression over some weeks, and subsequently a relapse. and biopsies taken from these relapse in comparison to pre-treatment tissues revealed that in 4 patients they analyzed, 2 of these patients had JAK1 or 2 mutations, and the third one had a beta-2 microglobulin loss, also indicative of no T-cell responsiveness of this tumor. So it's much easier to analyze only 4 selected patients and find something to be published in the New England Journal. If you analyze larger numbers, as I have shown you here in the previous slide, roughly 15% of patients having already a mutation in the interferon gamma signaling pathway, which is, so what consequence should we draw from that? Are these patients are not responding to checkpoint blockade? Should we eliminate these patients from treatment with checkpoint blockade? There are several ways to analyze that, and one way is, for example, nanostring analysis of formalin-fixed tissue, and then they have proposed a certain panel of genes which are potentially associated with PD-1 response. So developing a test for selecting patients as predictor for PD-1 blockade responsiveness. And Tony Rivas has published on that using the Keynote 001 patient cohort, the patient cohort who got treated with pembrolizumab. And there seems to be a correlation between the signature and outcome of the treatment. However, just remind you on what I have shown you on the analysis of the TCGA data, roughly 10 to 15% of the melanoma patients have pre-existing mutations already, and we have analyzed 169 pre-treatment by melanoma samples, and roughly 12%, 21 of those, had already pre-existing mutations in the pre-treatment tumor samples. And what is shown here is, for example, a group of these 21 mutated samples, and you see there are patients having mutations, but also a complete response here. Here's 2 others with partial responses, 3 other patients with partial responses upon treatment with nivolumab. Here's another one with a partial response upon treatment with ipilimumab. Here's another one with a partial response to ipilimumab. So obviously, pre-treatment mutation is not a safe way of predicting responses to a checkpoint blockade, whatever reason. So just to summarize now, I think there is resistance in the already primary resistance potentially in the tumor. And there might be adaptive as well as acquired resistance mechanisms. We have seen resistance which is happening inside the interferon gamma signaling pathway, and I have given you some examples with JAK1 and 2. We have obviously resistance if HLA class 1 is not on the cell surface anymore. The most common thing in melanoma is beta-2 microglobulin loss or mutations, but also HLA haplotype loss is a way to lose T-cell recognition. And this has been confirmed by others as well, mainly Tony Ribas' group. And there are several other ways which could lead to resistance, including also loss of neoantigen expression, which has been discovered, and also T-cell exclusion by Wnt signaling. Tom Gajewski's group has that described already 2 years ago. So these are the different mechanisms leading to resistance to immunotherapies and checkpoint blockade. And I think the way is not easy to move here forward. I think it's clear that we have chromosomal alterations and subsequent inactivating mutations in various genes in the interferon gamma signaling cascade. I have shown you examples for JAK1 and 2. these mutants evolve into T-cell resistant HLA class 1 negative lesions, which involve also genes in antigen presentation. And I have not shown you that, but this is also possible and happening, so that the antigen presentation is silenced and is not longer inducible by interferon gamma. Obviously, allelic loss of JAK1 and 2 is predisposing to interferon gamma resistance development, which is frequent in melanoma. There are selected subclones harboring inactivating mutations which emerge under various immunotherapies. I think that's a topic which has not been systematically studied so far, but these subclones are sometimes already detectable in pretreatment biopsies. And our data clearly demonstrate that JAK1 and 2 deficiencies protects melanoma from anti-tumor interferon activity and results in T-cell resistant HLA class 1 negative lesions. And we need to develop further screening instruments and also screens for better understanding of mechanisms of interferon gamma resistance. And probably over the next years, these instruments will be considered also for therapeutic decision making. And this is my final slide, thanking my co-workers, particularly Antje Zucker and Annette Parschen. And thank you for your attention. Thank you.
Well, performance. It was as good as we thought we were going to get. Do we have any questions at this stage? Anybody wish to? Yeah, Richard, there you go.
Great talk. Just wondering about the cases where you saw mutations in JAK1, JAK2, but saw a response, a partial response. Did you look at the immune profiling of those patient samples to see what the immune repertoire was like in those tumors, or there's perhaps an innate response going on in those cases?
So that's actually ongoing. Because we were hoping, obviously, that this test would enrich for patients who would benefit from treatment. Obviously, that's not so easy. That's not so. I mean, it's a matter of possibly heterogeneity, sensitivity, different metastasis. So I think it's currently unclear where this resistance should be measured, in my view.
It's always a great talk. A little bit in the same line, you are depicting all the missense mutation. Which of them are functionally inactive?
Okay, if you analyze that, it's roughly 50% of them which are truly inactive. So not all of them, indeed, are inactivating mutations. And so the next question you're having is obviously whether the inactivating are related to the. So that's not. It's not the case. So they are also inactivating. So not fully activated. So that was actually a challenge.
What about duration of response in those cases?
So as I have shown you, we have done that with mutational load, neoantigen. So there is a clear association if you analyze 100 patients with duration of response and benefit to treatment. The problem is that the overlap of the range is so large that for a personalized prediction or selection, these techniques are all not sufficient at the moment. So they are, for the group, there is a clear association. And if you analyze enough patients, it's statistically significant and good enough for a paper, but it's not good enough for decision making at the moment.
Sorry, at this stage, I'm going to close Dirk's presentation. I'm going to ask Richard Tothill to come up. And he's going to introduce Jurgen Becker. There will be time for questions at the end of Dirk's presentation. Sorry, at the end of Jurgen's presentation. Dirk has very graciously agreed after this meeting. He has a small amount of time before he leaves for the airport. But if anybody, particularly some of our junior staff, wish to call him and talk to him, I'm sure he said he'd be delighted to speak with you. Richard, over to you.
So, thanks, Michael. So, just by way of introduction, I'm Richard Tothill. I'm the head of the Rare Disease Oncogenomics Laboratory within the University of Melbourne Centre for Cancer Research. It's a great pleasure to introduce Professor Jurgen Becker today. Jurgen is a clinician scientist and with a strong interest in dermatology and immunology. He received his initial medical training in Germany and also in dermatology. Subsequently did research at Scripps Research Institute in La Jolla, California. He did his PhD at the Danish Cancer Center in Denmark, in Copenhagen. He became a full professor of dermato-oncology at Wolfsburg before he went on to become Director of General Dermatology at the Medical University in Graz, Austria. Finally, in 2014, he became the head of the Institute for Translational Skin Cancer Research as part of the West German Cancer Center at University Hospital Essen, and he's also part of the German Cancer Consortium DK-TK. So Jurgen is really a world leader in Merkel cell cancer research, and this is really, I guess, our affiliation that Jurgen and I are collaborating on a number of projects. Merkel cell carcinoma is an important disease in Australia. We have the highest incidence of this disease worldwide, but we're winners in terms of the research on this disease, and we're getting established here in collaborating with Jurgen on this. So today, hopefully, Jurgen will give a nice overview of Merkel cell carcinoma, educate you all on this rare disease and some of the great research that he's done in the last few years. Okay, thank you, Jurgen.
First of all, thank you for the kind invitation and the really kind introduction. It's always funny when you call me Professor Becker. I will be presenting a little bit on Merkel cell carcinoma. Just to give you like a little bit introduction to it, because it's a really rare disease and you probably see a lot of metastatic patients, but quite often, at least in Europe, the disease is not diagnosed in the hospital but in outpatient clinics, and usually it's like fast-growing asymptomatic, firm, non-tender, flesh-colored and red villaceous nodule with smooth shiny surface. So basically, it could be everything. So the clinical diagnosis is not really clear, and even if you take that textbook description of it, in the same textbook, on the lower part of the, it's given other forms. So it can be scaly, it can be ulcerated, it can be larger plaque, it can be just attached. So really, the clinical diagnosis is not easy. Similarly, with the histologic diagnosis, it's also taking out of the MOOC hematology. We have here a classical type. You see small round cells here in the larger magnification. You have some trabecular of stromal cells, and you also see, which makes it so difficult to treat, that there are micrometastasis just intermingling with the blood vessels around it. So what you see is also that sometimes the trabecular things are missing. Then this is called the small cell type, or there can be much more of it. Then it's a trabecular type, and this is actually what originally was described in the 70s by Toka and co-workers. But when you just look at these two types, which should be fairly easy to diagnose, the small round cell type, sometimes with the trabecular, there are also completely different types, like the large cell type, or sometimes you get this weird Indian filing. So also by histology, there are lots of differential diagnoses, which are not necessarily all the time as easy interpreted. And another thing is, which is particular about Merkel cell carcinoma, you sometimes see an epidermal association, which you would expect from something if it's from the Merkel cell, which is normally localized in this area, in the basal layer. but some quite more often you have no association to the epidermis whatsoever, so it's purely dermal Merkel cell carcinoma. So it's all in all not as easy to diagnose a model. Nevertheless, particularly you should know about it because this is the worldwide incidence, and this is a recent effort together with the IARC, led by or headed by Andreas Stamm from Essen, that we were taking together all cancer registries over the ever since they had been registered. This was like the latest where we had the large data set. So you see that there is a huge variation in the incidence of Merkel cell carcinoma. Don't be fooled by the white spots there. Basically, we don't have any data. So most of the data coming from the US, Europe, and Australia and New Zealand. And you see that in Australia and New Zealand, you got the highest incidence, particularly if you look for males, which is here really at 5 per million. So much higher than what you can see in Europe. So this is something really striking. But nevertheless, taking together, when I look around the room, it's probably as many Merkel cell carcinoma patients as people are here sitting in the room. So it's still a very, very rare disease. What are the risk factors for the Merkel cell carcinoma? And you see all of them is immune suppression. In the times of the AIDS epidemic, nowadays with this HART therapy, it's not as obvious anymore. There was an almost 15-fold increase in incidence with organ transplant patients. This is a 10-fold increase in incidence. What clinically is much more relevant is the hematological diseases, particular chronic lymphatic leukemia, where you see a 15-fold increase in incidence. And this is actually a fairly common disease, particularly since this is not necessarily advanced CLL, but all CLL, even sometimes CLL, which is only diagnosed after the Merkel cell carcinoma was diagnosed. And then there's particular in sun-rich areas, preponderance of the male sex. However, if you look in Europe or northern United States, there's actually a slight predisposing to the female gender. What all brings together is actually that all cases are more associated with UV radiation, even more when you got more UV. And one thing which is really nicely demonstrating this is when we look for the age standardized incidence rates together with the geographical latitude. So the smaller, the closer you are to the equator, and this here is Australia and New Zealand. You see that there's a strong association between the possible UV exposure and the incidence of Merkel cell carcinoma. In a matter of fact, this is much more evident than for melanoma, so really demonstrating the strong association of Merkel cell carcinoma with UV light. And again, here picking one of these epidermally associated Merkel cell carcinomas, and if you look for some of these tumors for the mutational burden, and Dirk was talking a lot about mutational burden in melanoma. This is just a circle plot, and see here you find a tumor which is actually as mutated as you can expect, actually usually more mutations than we find in melanoma. So this is really a tumor with a lot of mutations. However, the question is, how do you get UV there? Any good suggestions? It's normally UVB is just barely reaches the basal layer, and UVA maybe a little bit up to here, but not really there. And in fact, there was, besides the UV radiation, there was also in 2008 the discovery of the poliovirus, which was associated with there was a US series of 8 Merkel cell carcinomas, and 6 of them were bearing the Merkel cell poliovirus, so that you have probably 2 histories of Merkel cell carcinoma, one UV associated and one poliovirus associated. And here is also listed a couple of potential cells of origin. The Merkel cell as a pretty far advanced post-mitotic cell, not very likely. There's also some of the epidermal stem cells which are discussed, pro-B cells, particularly from some groups of the Netherlands, and also fibroblasts have been suggested as cells of origin. Again, it is some of them may not be exposed to UV light, and when you look at different Merkel cell carcinomas, you find, I mean, this is what I've been showing you before, but this is another example, and this is a tumor with very, very rare mutations. So you probably either have genetic propagation by DNA damage, most likely done by UV, or you got a pathogen perturbation done by the virome of Merkel cell polyomavirus, which then actually leads to very similar alterations in RB signaling, in inactivation, or aberrations of p53 signaling. Notch signaling is impaired. You see a lot of changes in chromatin modifiers and DNA damage repair, as well as in most Merkel cell carcinomas, you got an activation of the PI3 kinase ACT pathway. And either osteopathogenesis leads to very similar phenotypes in Merkel cell carcinoma, and by now we and many others are looking to find some differences to phenotypics of the different origins. A little bit for the Merkel cell polyomavirus, it's usually infecting some cells. We don't know the cell of origin. Then the genome of the Merkel cell polyomavirus is integrated in the host genome, and it's clonally integrated and leading to proliferation. And interestingly, if you interfere with the function of the T antigens, both small t and large T antigen, this leads to cell death and growth arrest. In our hands, the large T antigen is more responsible to maintaining the tumor phenotype and to keep the cells alive, whereas the small T antigens seem to be more active in transformation. However, when with this information only, I mean, the virus was discovered in 2008, and already a couple of years later, it was really associated with really not only associated but positive for Merkel cell carcinoma. This was for viral carcinogenesis very fast. The other thing is what was obvious, that since the T antigens are needed really for maintenance of the oncogenic phenotype, the virus is here. It's demonstrating the integration of the virus into the genome, and here in histology demonstrating that the large T antigen is highly expressed in Merkel cell carcinoma, and in all virus-positive tumors actually I was looking at, you see expression of the respective protein. When we get back to clinical appearance of Merkel cell carcinoma, it usually starts with a primary tumor. When it gets removed, you, in a substantial degree of patients, at least depending on whether you use adjuvant radiation or not. If you're not using it in more than 1/3 of the patients, you see local regional recurrences, mostly occurring within the first 2 years. Then in a substantial number of patients, there are also lymph node metastases. As a matter of fact, already at primary diagnosis, more than 30% of the sentinel lymph nodes are clinically positive, and then later on you have distant metastasis. There is a new staging system, and at the melanoma meeting, there was a new staging system on melanoma described. There's also a new one for Merkel cell carcinoma. It was not changing as much as was changed for melanoma. The biggest difference which was introduced is that we now really distinguish between a clinical and pathological stage, whether the absence of lymph node metastasis is really demonstrated by biopsy of the sentinel lymph node, either as a complete excision or as a fine needle aspirate, or only clinically. And most of the patients who only are on the clinical stage actually should be the other way around, because they have a much worse prognosis than those where you have true pathological confirmation that the tumor, that the sentinel lymph node is free of tumor cells. So this is reflected here also by some other means, and here we were doing some DOTA-PAF PET. Here is actually the primary tumor, and here you see how the sentinel lymph node was demonstrating, and this was actually in micrometastasis. So here, using the respective PET tracers, DOTATOC or DOTATATE, are highly sensitive, particularly in the earlier times of the history of Merkel cell carcinoma. In more advanced stages, the somatostatin receptors are frequently lost, but in early stages it's frequently there. And again, I was already mentioning that at the primary diagnosis of Merkel cell carcinoma, 30% of the patients already have a positive sentinel lymph node, and which is interestingly, because it's somewhat differently seen by some centers in the US, that this not necessarily depends on the size of the tumor, but if you go for the diameter of the tumor, you see positive sentinel lymph node already in small Merkel cell carcinomas, really demonstrating that the sentinel lymph node biopsy, which is fairly easy performed, is a very strong diagnostic tool. With respect to prognosis, of course, lower stages are better than higher stages. Females are doing better than males. What is quite obvious also later on for therapy, that localization matters, that head and neck is much worse than the extremities, and with respect to morphological markers, small tumor size is not that good, high density of blood vessels, and what had been already mentioned, that loss of class 1 molecules in melanoma expression is also a negative sign. What is a positive sign is solar elastosis as well as an inflammatory infiltrate in the tumor. Another thing we observed with respect to prognosis, this was a small study where we looked for one of the transcription factors which are leading to the differentiation into neuroendocrine cells, which is ARTO1. And you see that the patients with a relapse have a higher expression than without a relapse. This is really a small study, and wouldn't test ARTO1 expression routinely in patients. But what is interesting is that this ARTO1 overexpression is present also in Merkel cell carcinoma cell lines. And ARTO1 is one of the effects is that it binds to the promoter of a microRNA, microRNA 375, which had been described before as highly associated with Merkel cell carcinoma. And you can see here that in our Merkel cell carcinoma cell lines, most of them are really highly positive. You see that there are 3 cell lines which are always dropping out, and these are actually cell lines which we are not sure whether these Merkel cell carcinoma cell lines, because they have a completely different growth patterns, all are virus negative, and lack also some other markers for Merkel cell carcinoma. And as a matter of fact, Katrin, who's sitting in the audience, is currently performing a study comparing these cell lines to each other and to figure out what these 3 truly are. So this just gives a correlation between ARTO1 expression and expression of the microRNA. So we asked ourselves, okay, this is associated with the worst prognosis. What happens when we impair with the function of this microRNA? And actually not much happens, and just gives you the growth capacities. These are 2 cell lines, either with or without activity of the microRNA. Not much changes, the morphology stays the same. We were looking also at signaling pathways in EMT and Hippo pathway, which are associated with microRNA 375, and we could never see anything what is there. So we asked ourselves, why is it there? And then we realized that there are a couple of microRNAs which are overexpressed in Merkel cell carcinoma, and we were doing a screen, and there are the top hits. But actually, only microRNA 375 was also detectable in the cell culture supernatant. So it's kind of like somehow getting out of the cell into the supernatant. And we were asking ourselves how. And a lot of things, especially with microRNAs, they are exported by within exosomes. So we first established an assay to see whether we could truly isolate exosomes, and the exosomes are here, and we were just using beads to for size comparison. So this is pretty much in line. And when we look for the expression of the of microRNA 375, either in the culture supernatant or in the exosomes, you see a strong enrichment in the exosomes. And usually when something is transported in the exosome, this is used for intercellular signaling or communication. And we wondered why, which cells may be affected. And since I've demonstrated to you that the tumor stroma plays a dominant role in Merkel cell carcinoma, we were looking whether these are actually also infecting, these microRNAs are affecting fibroblasts. And we first looked at, we did the line, can we look at that one? Great. Then you don't not only have to believe me, but you can see that we labeled the exosomes in red, and we're just putting it on the fibroblast. And you see here is a fibroblast cell line MRC5. There's this rapid uptake of the exosomes, and seen in primary fibroblast that this is really uptaken and probably has an effect, which we next checked. And what we found here, and this is a complex slide, but it's actually very simple. We first demonstrated that if we use culture supernatant, transwell chambers, or direct co-culture, that the microRNA 375 is taken up into fibroblasts. These fibroblasts do not have any pre-microRNA, so it's not a contamination of the co-culture system, whereas the tumor cells itself have a lot of the pre-microRNA. And within this co-culture system, on the fibroblasts, either with supernatants or in the transfer chamber or direct co-culture with tumor cells, there's a strong induction of alpha-smooth muscle actin, CXCL2 or IL-1 beta, all markers for cancer-associated fibroblasts. And since with alpha-smooth muscle actin, this was the strongest induction, we also looked on a protein level, and we saw a strong induction both in the fibroblast cell line as in primary fibroblasts by the uptake of the exosomes. This also translated in morphological changes, again with here MRC5 and the primary fibroblasts, which are now starting to express the alpha-smooth muscle actin, and also they are getting into a different shape, which is more what you expect from senescence or cancer-associated fibroblasts. So next step, we tried to block that, and therefore we transfected the fibroblasts with antagomeres, and you see not that strong inhibition, but a clear trend of the inhibition, which is also due to the fact that antagomeres are not working that great, but it's always in the same trend that the effect of polarization of the supernatant could be overcome by, at least in part, by MIR375. The other what we have to keep in mind is probably more than this microRNA, which leads to the polarization, but at least demonstrate that this is a strong part of it. Next step is to translate that into the clinic, and we did an ISH together with colleagues from Denmark for microRNA 375, and you see a strong expression in the tumor cells. But if you look closer, you see also that there's a signal within the fibroblast indicating that this is happening indeed also in vivo. And when we also correlated the expression of microRNA 375 with alpha-smooth muscle antigen expression, you see that it's also there is a correlation with it, demonstrating that some of the polarization effect is indeed induced by this microRNA, so that the effect of the overexpression of this microRNA is not necessarily directly impacting the tumor cells, but changing the tumor microenvironment. Now, switching a little bit back to the clinical part and getting into how Merkel cell carcinoma in advanced stages is treated. Until recently, actually 2 years ago, the standard of therapy was systemic chemotherapy, and together with Paul Neal, we were performing a systemic literature review. This is not the literature review, but that's personal experience. This is a patient receiving chemotherapy and actually having an initial partial response, but very fast the patient is actually deteriorating because the tumor is progressing. And the summary of that review, you don't have to read it, that chemotherapy may have high objective responses, but these are very short-lived, and there are no really randomized trials. There's still no randomized trials, but there's never a correlation between objective responses and overall survival, and there's no confirmed correlation between dose intensity and response. And everyone on that review, and also when we had discussion on with the NCCN or with the German guideline, that cytotoxic therapies are only recommended in symptomatic patients refractory to other treatment options. So this is really last line now, and something which has been decided for a long time, but was always very frustrating. It still can control symptoms, but it's not really helping the patients in the long run. However, when you look at Merkel cell carcinoma, even though it's a rare tumor, but if you look at case reports or small case series of spontaneous regressions, you find surprisingly lots of such publications. And this is really indicating, together with the fact that a lot of the patients with Merkel cell carcinoma are immune suppressed, that these are it's also a tumor which is controlled by the immune system. And this is just demonstrating just one of these tumors, how they are regressing. This is the tumor when it was diagnosed by biopsy, and later on there was a complete regression of it. And I must say that several such tumors where you had a complete regression of substantial tumors, and we could find nothing afterwards. So really, immune system plays a strong role. And together with Paul, a couple of years back, we tried to look for a prognostic signature in Merkel cell carcinoma, and what we found, and you can really read it here, but these are mostly genes upregulated or associated with the T-cell infiltration of it. And if we just look for a T-cell infiltrate within the tumor as compared to absent T-cell infiltrate, you can see that the good T-cell infiltrate is usually associated with an improved prognosis. This can be easily explained. And what I also should say, this was a series of 40 patients which were collected, and only part of them were viral positive, the other part were virus negative, and we did not see any difference in there, which can easily be explained by the fact that if you got a virus there and you have to express, or the tumor cell has to express it for mediating the oncogenic phenotype, you have a very nice presentation of viral peptides. So there's this really strong foreignness in there. In the case of UV light-induced carcinogenesis, you got lots of mutations, which also causes presentation of neoantigen. And this is that viral antigens can be recognized, is demonstrated here using the work together with Tom Schumacher's group, using that we predicted the respective epitope, then we're selecting it by creating peptide MRC complexes, which had been also then used for color-coded and for staining. If we could demonstrate that Merkel cell carcinoma patients have responses to viral epitopes, which can also be detected in situ as demonstrated here, and here together with the staining of CD107A, which is normally on lytic granules, which is then on the surface, so that it's really demonstrating that these are functional active. If we got these responses, you usually got also escape mechanisms. One ongoing response, in particular, once you see a tumor, and Dirk was already alluding to impairment of class 1 procession or antigen processing. There is a lack of activating ligands or induction of inhibitory ligands, here mostly PD-L1, and this was leading to lots of clinical trials where PD-1 or PD-L1 blockade had been tested, and this was really highly successful. I guess it's very fast become standard of care even before FDA or EMA was approving it. I don't know about the approval status in Australia, but I guess this will be also pretty soon approved. EMA approved it in September, and this is true actually for all, either if you use pembrolizumab, avelumab, or nivolumab, there's virtually no difference in it. This is just demonstrating one of the patients where you had a large subacute tumor mass here after a couple of weeks of treatment, already an ongoing visible, clinically visibly response. However, and in this respect, I'm similar to Dirk, you also see then resistance mechanism. This is only a couple of weeks later. So also here, resistance mechanisms are ongoing. So what we actually tried to do, provide some immune monitoring or understanding which patients are primary or secondary refractory to PD-1, PD-L1 blockade. And this is now really a real-life experience in essence. And this is a summary. This is 25 patients, as you've seen before. They had been treated either with pembro, ave, or nivolumab, so all different forms of blockade. You see none of the treatments is better than the other, so this is very well distributed. We looked for some clinical markers like gender, age, pre-treatment chemotherapy, localization of the primary, and the mixture in the first site. It's very not pointing completely to one direction. So we looked for PD-L1 expression both on the tumor cells itself as well as on the stromal cells. And one thing we observed is that the tumor cells are only to a small degree positive for PD-L1. It never accessed more than 30%. And there's also no correlation with, as also demonstrated by the other trials, there's no correlation between PD-L1 expression and response to therapy, neither with the virus. We also looked for previous chemotherapy, as mentioned before, and in difference to what others reported, we don't see a benefit in those patients who had been treated in first-line therapy, which is good for the patients receiving therapy, which became quite obvious that a good performance status is a good prognostic sign, and also that higher age is a negative predictor for response. So this remains to be investigated. What are the reasons for this? And we carried on not only to use these standard markers, but also to use some additional assays. And I only want to talk, for the sake of time, for the multiplex immunohistochemistry, chemical staining, as well as gene expression by nanostring. And this is two patients depicted here, before therapy, a non-responder and a responder, and they look actually very similar at that time point. So in both there's this sparse but present infiltrate of both CD4 and CD8 T cells. And but if you look after therapy or under therapy, actually, you see that nothing happens in the non-responder, whereas the responder has a strong infiltrate of both CD4 and CD8 positive T cells, indicating that this is really happening. We also then try to set out to characterize the characteristic of the T cell infiltrate before and after therapy, and therefore we used the nanostring analysis, the immune panel. And what is obvious, these are genes overexpressed in responders, and this is non-responders. You see that here T cell function genes are clearly overexpressed, and this was largely associated with an overexpression of genes of the antigen processing machinery necessary to present MHC class 1 molecules on the surface. And I already mentioned that class 1 expression is frequently downregulated in Merkel cell carcinoma. Here the stroma is a positive control, whereas the tumor cells are negative. So more than 1/3 are completely negative. Another 2/3 are actually not another half is actually really low expressing MHC class 1 molecules, and only very few cells are expressing it highly. This is nicely reflected by the overall survival in these patients, and this is the patients with HLA class 1 expression, and this without, so really demonstrating that you need some class 1 to do it. In order to further analyze it, we checked out whether our cell lines are reflecting this picture, and indeed it was so that we got some cell lines with almost no class 1 expression, very low class 1 expression, or a decent class 1 expression, also seen here by immunofluorescence. And what you see already in these pictures so much better here, that also the negative ones are not completely negative, but what is just lacking, that the class 1 expression is only within the cell and not on the cell surface. And when we remember some of the slides Dirk was showing in his presentation, that for class 1 expression, the class 1 molecule has a heavy chain, which we are detecting here, together with the beta-2 microglobulin, and all this is stabilized by the respective peptide which is presented. And what you actually see is that you have class 1 expression, but here you don't have it on the cell surface. So either something with the antigen processing machinery or with the beta-2 microglobulin might not be working. So we perform Western blots confirming that class 1 is present in the tumor cells. Also that in this Batman blot, we see that beta-2 microglobulin is there. It's surprising how little good antibodies are available for beta-2 microglobulin. And then when you look for the antigen processing machinery, you see actually that these are only present in the cell line which are expressing on the cell surface class 1 molecule, and the others are very low or virtually absent. And when we, in order to confirm that this is really the lack of class 1 expression is due to an impaired antigen processing machinery, we added some peptides to the cell lines and followed up the class 1 expression, and you see a shift towards more positive cells, which could be quantified here. So demonstrating that by stabilization of class 1 molecules on the surface, by adding peptides, you could rescue the loss of class 1 molecules. What also became obvious is that if you look at class, how this might be regulated, we look at the histone acetylation, and it's clear we see that most of the cell lines, the histones are hypoacetylated, which can be rescued by histone deacetylation, histone deacetylation inhibitors, HDAC inhibitors, so that you got an upregulation. More important, if you look specifically for the reporter of the region of the respective molecules of the antigen processing machinery, this is also the case, and this leads to re-expression of these molecules, and even more important, re-expression of class 1 molecules on the cell surface, not only within the cells, as depicted here and here. You can also see it here. And by PEX analysis, that by HDAC inhibition, you get a nice reinduction of class 1 molecules, and it's quantified here. We tried to do that in former times with interferon, but interferons are actually molecules described as something which interfere with viral infection or viral maintenance, so that they also downregulate the expression of viral proteins. And if you got a tumor which foreignness is given by the expression of viral proteins, if you downregulate them, doesn't really help if you upregulate the class 1 molecules. And what you see here, by treatment with the HDAC inhibitors, you do not see interference with expression of the viral proteins, showing that this is something nice to put to something. Sorry, it would be something interesting to combine to boost immune responses to Merkel cell carcinoma, because if you take, and this is taken out of the avelumab trial, 1/3 of the patients are nicely responding, others are not really responding, but then there are also some which are responding and then progressing. So for these patients who have primary resistance and may not express class 1 molecules, addition of an HDAC inhibitor might be quite helpful. It also indicates that the response to therapy is very fast in Merkel cell carcinoma, and also if you don't respond to Merkel cell carcinoma, it's really taking off, and really the tumor is highly progressive. So it would be very good to have something to monitor these patients very closely, and therefore biomarkers would be very helpful. This is just the classical definition of the biomarker, that it should help you to monitor the tumor. There are different types of biomarkers, surrogate markers, which just reflect tumor burden. Then you got some prognostic markers and predictive markers, probably like the we hope for the interferon mutation in melanoma to predict whether they respond to it or not. However, it's always to keep in mind that these biomarkers are not serving just one purpose, but sometimes several. If you go to biomarker sessions, there can be lengthy discussion whether it's a surrogate or prognostic or predictive biomarker, but it's really not easy to distinguish. But biomarkers should be something specific, expressed by the tumor and released by the tumor. And you already know that microRNAs 375 might be a good candidate to do that. And also, if you know that microRNAs are really stably stable and you can detect it in serum, plasma, and urine. And here, probably go ahead. So we tested this in our model system we're using. It's either the chicken cam model or a xenotransplant model. And in both models, there's a strong association of the presence of that microRNA in the serum, depending on the presence of the tumor. So the next step was to have a clinical trial where we initially started with a small cohort in Graz from Austria and extending that to a cohort from Seattle, from Paul Neal's group, and we found some interesting results, which you will see in a second. But then we actually submitted it and got said, hey, come on, you have to do remark criteria, so you need prospective samples. So there were prospective samples within the Essen group, as well as here from Melbourne, so which is really depicting the demonstration just here. So there are two retrospective cohorts and two prospective cohorts. And when you look at here the presence of tumor cells or no evidence of the disease, you see a very good correlation with good ROC analysis with an ROC of greater than 0.9. This was also true with not such a good RSA with the Seattle cohort, but when we go into two prospective cohorts, this was really very well associated. And when we look for correlating with tumor stage, it was like between stage 1 to stage 4 that the serum levels were increasing, which was not the case in patients with no evidence of disease, really demonstrating that this increase was due to increased tumor burden. And together with Ron Hicks and Richard, we were also not only doing for the presence, but also looking for the tumor volume. And this is demonstrating here that the patient first got radiotherapy and chemotherapy. The tumors got smaller, and also the microRNA dropped. When there were recurrence, the microRNA was increasing again. Then the patient received immunotherapy by a PD-1 antibody, wasn't it, by the IG? Yeah. So then it dropped again, and the beauty of it that it drops really fast after induction of therapy. This is in the other way around. If the patients are progressing here under chemotherapy, you get also an increase of the microRNA level. And here again, patients receiving immunotherapy, which leads to a steep drop of the level of the microRNA. And so on. And this is actually not only true for these two cases, but several other cases always have a very good correlation between tumor burden and the level of the microRNA. And with this, I'd like to stop. This is basically the diagram of therapy algorithm for how Merkel cell carcinoma should be treated from the beginning to the ending. And this is was actually also done together with colleagues here from Australia and from the US. So this is kind of like a summary of the treatment algorithm both in US, Europe, and Australia. And this will come out in the beginning of November. Thank you very much for your attention.
Thanks, Jurgen. That's some of the force of Merkel cell research and also the clinical side. I'll open up to questions from the audience. Does anyone have a question? I'll ask the question. Do you think that HDAC inhibitors will potentially work on tumours that have JAK1, STAT1 mutations?
Probably it depends on the JAK1, STAT1 mutation.
Right. I mean, truncating, would it be a rescue from, I guess, resistance to interferon?
This will be difficult to see, but the thing is that the HDAC inhibitors probably have more effects just on class 1, also on MIG-A, so in case that we play also a role. So that probably the clinic will have to demonstrate, and we're currently planning a trial together with a German company to test the addition of HDAC inhibitors to patients who fail PD-1 blockade by itself.
So this is a clinical question, one that we've debated in our multidisciplinary meeting a little bit more recently. So of course the evolvement second-line data suggested that the response rates were considerably lower compared to the pembrolizumab data. But of course the pembrolizumab had a proportion of stage 3 patients in there. So the question, when faced, certainly practice differs from country to country. In Australia there's been a tendency towards using adjuvant chemotherapy or chemoradiotherapy. And I'm keen to hear your perspective about the impact of chemotherapy in that setting in terms of perhaps impacting subsequent, a substantial proportion of these patients unfortunately relapse, and then the impact of that on responses down the track.
Okay, good question. First of all, I never was a fan of adjuvant chemotherapy because I'm coming out of melanoma and where it never was successful. With respect, if you look carefully at the data of the trials, the ones showing the best responses were mostly the ones with not non-visceral disease, or if visceral disease, it was lung metastasis. And actually, all of the complete responses were like in non-visceral disease. So I'm not sure whether the adjuvant or the pre-chemotherapy or the advanced stage of the disease. When you look also at the age distribution in the Avelumab second-line trial, the patients were a couple of years older than in the pembro data, and also in the Nivo data. So I'm not sure whether adjuvant chemotherapy will harm it. I wouldn't do it either, but I think there's no point in not treating the patients. And as demonstrated by the cohort from Essen, we also don't see the dependence of pre-treatment or non-pre-treatment. It's much more the performance state and the age what we follow.
Are there any more questions? I probably have to wrap it up. I think it's been fantastic to have Jurgen Dirk here present today. It's been quite informative, and let's just thank Jurgen Dirk for their